Worldwide, each year, 1.4 million children are born with congenital heart defects, and over 350,000 children acquire heart disease. You are taking care of them. The vision of the World University for Pediatric and Congenital Heart Surgery is that every healthcare professional, anywhere in the world, involved in the care of patients with pediatric and congenital heart disease should have access to ongoing education. Education, communication, mentoring, knowledge everywhere and for all. Imagine being part of it.
I am P.S. Manchatiwat from Bangkok, Thailand, along with my co-chairs, Dr. Michael Mitchell from the USA and Dr. Ignacio from Argentina. It's my great pleasure to welcome you to the World University for Pediatric and Congenital Heart Surgery 16th educational webinar. The subject for today is left ventricular outflow tract obstruction number 2, Subvalvar and Supravalvar Aortic Stenosis. During this 2.5 hours session, we are honored to have world expert international faculty members who will discuss important topics related to the management and surgery for the left ventricular outflow tract obstruction. So please take a moment to note that there are no conflict disclosures for this webinar. Each presentation will be approximately 8 minutes, with 6 minutes reserved for questions from the audience. Please note that to maximize everyone's learning enjoyment of the educational material, the audience computer microphones will be muted. However, we encourage you to ask questions through your chat function on Zoom. To submit a question, open the chat function, select the moderator's name, type in your question, and place the Enter key on your keyboard. Also, please note that the program is recorded and will be available on the WUPCSH website within a couple of weeks. So let's get started with the program. Ignacio, please. Thank you.
You're muted.
Sorry. So it's welcome everybody. It's a pleasure to introduce Dr. Vera Aiello from Sao Paulo, Brazil. She will deliver a talk about anatomy and morphology of subvalvar and supravalvar aortic stenosis. Please, Vera.
It's a pleasure to be here. Once more, I want to thank the organizers. From the Heart Institute of São Paulo in Brazil. It's a pleasure to be here today talking about the morphology of the obstructive lesions at the subvalvar and supravalvar left ventricular outflow tract. I thank the organizers for the very kind invitation. I have no disclosures. First of all, I'd like to briefly review with you some points of the anatomy of the left ventricular outflow tract. You see here in this longitudinal section, the apical component of left ventricle and the outflow tract. That's not a complete muscular structure. In fact, some part of this outflow tract is composed by a fibrous structure that is the anterior leaflet of the mitral valve, and the other parts are muscular. So it's my task today to talk to you about the subvalvar and the supravalvar lesions causing obstruction. The valvar lesions were dealt with last webinar by Justin Tretter. So another point that I would like to emphasize with you that's very important is the topography of a very important structure that is the conduction axis, the conduction tissue. And so any intervention in this area should take into account the presence of this structure here. So in this close-up view of left ventricular outflow tract, we see the aortic valve, the left coronary leaflet and sinus, the non-coronary leaflet and sinus, and the right coronary leaflet and sinus of the aortic valve. So transilluminated, we see here the membranous septum, and here's the area of fibrous continuity between the mitral valve and the aortic valve. This dashed line shows clearly that the left bundle branch emerges exactly between the membranous septum and the muscular septum, just below the commissure between the non-coronary and coronary, right coronary aortic leaflets. So this is very important to avoid a lesion of the conduction axis in this area. The obstructive lesions of the outflow tract may be divided in subvalvar, valvar, as I told already, discussed by Justin Tretter, and supravalvar. The subvalvar lesions may be called fixed when there are membranes, like I will discuss with you, deviate the outlet septum in the context of the presence of a VSG, the presence of tissue tags or aneurysms of the membranous septum, anomalous chordal insertions, bulging septum, and also tumors. It's called dynamic in the presence of the asymmetric hypertrophic cardiomyopathy, a genetic cardiomyopathy, as I will discuss with you briefly. And the supravalvar lesion, that's the typical lesion in Williams syndrome, like hourglass lesion, as also I will discuss with you. Let's start with the subvalvar membrane. So I have to say that it's not a membrane, it's very thick fibrous tissue or fibromuscular tissue, like a ring below the aortic valve. So this is not membrane, this is very hard structure. And like I told you, completely circular, and may or may not be associated with other lesions, like for example, VSD or other obstructive lesions, as I will show you also. The tissue tags are lesions to the membrane, but they are not continuous, they are not ring-like, they are spotty, like we see here, very focal areas of fibrous tissue just below the aorta. And of course, the aneurysm of the membranous septum is located at the area of the membranous septum, and usually is not very hard tissue, it's very soft tissue. We should also remember that the left ventricular outflow tract obstruction may also occur in the context of discordant ventricular arterial connections, like in classical transposition of the great arteries, here the left ventricle giving rise to the pulmonary trunk, and here also the left ventricle giving rise to the pulmonary trunk, here in congenital correct transposition with the right-sided left ventricle. So the membranous septum may be aneurysmatic in both situations. Also lesions of the left ventricular outflow tract, but not subaortic, but subpulmonary, of course, because of the discordant connection. Another kind of lesion I should mention is the presence of anomalous chordal insertions. Usually the mitral valve has several insertions in the septum in this anomaly, and also anomalous papillary muscle like we see in this case. A common form of left ventricular outflow tract obstruction is the deviated outlet septum. Of course, in the context of a perimembranous or muscular outlet VSD, you see here the dotted lines are over the outlet septum that is completely deviated and from the trabecular septum here. The patient had been operated but did not survive surgery. These are very severe cases, and there is a posterior deviation of the outlet septum. Of course, there must be a VSD, and usually this lesion is associated with obstructive lesions of the aortic arch. We also we should mention also Schaff syndrome, that is a combination of obstructive lesions of the left-sided structures with parachute mitral valve, like you see here, the left atrium dilated. Here, a very stenotic mitral valve with a single papillary muscle receiving all the chordal attachments of this valve. The same case showing the outflow tract, subaortic membrane, and a stenotic aortic valve, and hypoplastic ascending aorta. So these combinations receive the name of Schaff syndrome. I need to show you also the asymmetric hypertrophic cardiomyopathy that is usually known as a dynamic form of obstructive lesion. This is a genetic lesion. And grossly, we see that the septum to free wall ratio, the thickness, is greater than 1.3. And see here the thickness, and also there is a restrictive physiology with very small left ventricular cavity, and also fibrosis. The lesion has a genetic background, and is due to mutation of several sarcomeric proteins. Histologically, we find myocardial disarray that you see here, several bundles of myocardial fibers in different directions. And this is very typical of asymmetric hypertrophic cardiomyopathy. This is the same case, but the other half, the anterior half of the heart. You see here the left atrium, the right atrium, and here the very thickened mitral valve. And during systole, this mitral valve, due to venturi effect, it is dragged against the ventricular septum, and there is continuous impact of this leaflet to the septum. And when we lift up this leaflet here, this interior leaflet, we see that in the subaortic position, there is a mirror image of the lesion due to contact, to the continuous contact of the mitral valve against the septum. So this impact lesion also increases subaortic stenosis besides the very huge ventricular septum. Another lesion that I should mention is a rare lesion, but may be congenital, is the presence of tumors like this one, several rhabdomyomas in the left ventricular cavity, at least 2 bulging below the aortic valve, and the child died due to obstructive obstruction of the systemic flow. Histologically, these tumors are composed of the typical spider cells that are very primitive cardiomyocytes. Another lesion causing subaortic stenosis is the one caused by bulging of the septum in cases of pulmonary atresia, intact septum. You see here the massive right ventricle is no cavity, just myocardial sinusoids, the bulging septum, and when we open the left ventricular outflow tract, we see this bulging septum below the aortic valve. The last lesion I would like to show you is the typical lesion of Williams syndrome. You see here the hypertrophy of the left ventricle, but it's symmetrical, not asymmetrical. And you see also that the walls of the aorta are very thick, and also the aortic valve is thickened. And so this lesion forms the so-called hourglass lesion. So at the area of the sinotubular junction, there is a stricture, and but everything is stenotic. And this kind of lesion is reported in up to 70% of Williams syndrome patients. So I will stop here, and I thank you very much for a very kind attention.
That was an excellent talk and summary. Thank you very much. We're waiting for some questions to come in, but perhaps I'll lead with one. When you're thinking about these lesions, particularly the tags, the subaortic membranes, and also the impact lesions, yes, which we deal with and we wrestle with recurrence of these, do you think of them as primary lesions or as lesions that develop in reaction to turbulence from other source?
Thank you very much. This is an excellent question. Of course, membranes and tags are congenital, but may increase over time. And as we see, like the impact lesion in hypertrophic cardiomyopathy. So sometimes when there is resection, we expect that some turbulence will be found there, and perhaps not, the complete lesion will recur, but some kind of endocardial fibrosis and fibroelastosis. So, well, I think the membranes are definitely congenital, but after resection, we can have acquired obstruction.
Great, thank you. Perhaps we'll progress to the next talk.
Thank you very much.
Okay, Mike. It was a very nice talk, Vera. So to move on with the program, our second talk is going to be delivered by Dr. Saurabh Kumar Gupta from New Delhi, India. His talk is going to be imaging of subvalvar and supravalvar aortic stenosis.
Yeah, thank you, everyone. And I'll just share my screen. In the meantime, greetings from India. Good day to everyone. I hope my slides are visible.
That's perfect.
Yeah, okay, thank you. So at the outset, I must thank the organizers for allowing me to present this talk in World University Forum. I would start by saying that purpose of imaging is insight and not pictures. And in the next 10 minutes or so, we'll try and see what imaging can provide in the lesions which are causing subvalvular or supravalvular obstruction. Now, this is what comprises in left ventricular outflow tract obstructions. And to do justice to the topic, I'll restrict to concordant connections at AV junction and PA junction. And as we know that last time the valvular component has already been covered, so we'll focus on subvalvar and supravalvar. I will first talk briefly about hypertrophic obstructive cardiomyopathy, where we know that the systole has three phases: eject, obstruction, and leak. Systolic anterior motion of the mitral valve and dagger-shaped Doppler trace is the characteristic of dynamic subvalvular obstruction. And I'll not go further into details because I suppose that for the given time, I'll be able to do justice only with fixed obstructions at subvalvar and supravalvar lesions. Now, this is what we mean when we are talking about fixed subvalvular obstruction. And this comprises of discrete subaortic stenosis, which accounts for nearly 90 to 95%, which includes both thin membrane and thick fibromuscular ridge, or it may be of tunnel type. Fortunately, it is less than 5% of these total fixed LVOT obstructions, and others may constitute another 5%. Now, these are various types. And for the sake of this presentation, we'll focus on these two because this is the major chunk which will be seen in our clinical practice. Now, we touched upon this concept, whether it is truly a congenital heart disease, and most of the people believe that subvalvular aortic stenosis is not strictly a congenital heart disease. It is probably a reflection of altered shear stress, and possibly it is also contributed by increased aortomitral separation, although it is not proven which is causing what. Now, when we talk about discrete subvalvular membrane, we must realize that it also affects the adjacent structures. So it may also include fibrous lesions on the aortic valve as well as on the mitral valve. So whenever we are assessing these lesions, we must look for adjacent areas because the abnormalities can be there in those areas. Now, other points which are worth remembering whenever we are imaging a patient with subvalvular stenosis are that the associated lesions are common. Other LV inflow and outflow obstructions may coexist. Mild AR is seen in more than 50%. Fortunately, it is usually mild and there is slow progression. P gradient more than 50 millimeter of mercury predicts faster progression of both LV outflow obstruction as well as AR in post-op setting. And there is high risk of recurrence. It is even higher if the patient is operated in childhood. Now, these are various indications. I'll not go there, but I would like to say that discrete subvalvular aortic stenosis probably develops left ventricular dysfunction faster than valvular aortic stenosis. Since they are unlikely to require an aortic valve repair, thresholds may be kept lower. But if it is complex subvalvular LVOT obstruction, recurrence is high and the surgical outcomes are worse. So that should be kept in mind whenever we are imaging and managing these patients. This is a less known thing in the clinical setting that some of these thin membranes which are away from the aortic valve may be treated with balloon dilatation, but the patient selection has to be perfect, which means that this is a thin membrane which is lying away from aortic valve, and this is all we need to see during imaging. Now, when to suspect fixed subvalvular aortic stenosis is relatively normal valve, turbulence starting below the aortic valve. This is the position of the valve, and we are having obstruction turbulence starting here, presence of aortic regurgitation and aortic valve flutter. These are the things which when we see on echo, we start thinking that we may be dealing with subvalvular aortic stenosis. Now, these are various components of imaging subvalvular aortic stenosis. For the talk, what I'll do is I'll take one index case, show the images, and we go along with various steps of preoperative imaging. Now, first we assess the severity of LVOT obstruction, and this is done in standard apical, suprasternal, and hypersternal views. The imager must be conscious of the limitations which echo provides or echo has at the time of evaluation, like there can be contamination of the LVOT Doppler by MR or VSD, and that has to be kept in mind. The severity of LVH again provides indirect clues towards severity of LVOT obstruction. Now, then the next thing is to locate and define the left outflow tract obstruction. Like in this case, we can see the membrane clearly over here, and that is very close to this aortic valve leaflet. Next is to assess the morphology and function of aortic valve and mitral valve. Since I have already told that these lesions, when they are closer to the aortic valve, they can cause lesions at the aortic valve as well as in the mitral valve. Tunnel type of LVOT obstruction may have smaller aortic valve annulus because of the continuously reduced flow across the aortic valve, which is not allowing the aortic valve annulus to grow. Aortic valve may be abnormal, A thin membrane away from aortic valve may respond to balloon dilatation, and more importantly, AR assessment may be imperfect with obstructed LVOT and associated lesions. So we should not fall back too much on the AR assessment, and we have to see everything together. Next is to look for associated lesion. Like in this index case, this patient also happened to have a large PDA. And because of that, this associated PDA led to problematic assessment of aortic regurgitation. And that's what I highlighted in my previous slide. Now, this is what is a fibromuscular ridge. If you notice at this point, the AML is showing tenting. That is probably the AML side of the ring, which is shown like this. This is tunnel type of subvalvular AS. This is very important to identify because these patients would probably require cono procedure, and this will be dealt later by in the next presentations. They usually have high rate of recurrence and has worse outcome. Schonn's complex, again, has to be seen. A supravalvular or a supramitral ring is seen in this case. So this has to be identified. Otherwise, this lesion may be not treated, and when we are focusing only on the LVOT obstruction. Other mechanisms may be, like in this case, in AVSD, the mitral valve tissue or the left AV valvular tissue may get into the LVOT, and that may cause LVOT obstruction. PE sometimes can delineate it even further, as in this case, accessory mitral valve tissue is getting just below the aortic valve and causing LVOT obstruction. And in this case, if you see carefully, the membrane is adhered to the right coronary cusp and is causing restriction of this aortic right coronary cusp, which is also contributing to aortic regurgitation in this case. 3DT can further clarify that this membrane is circumferential and not slit-like as we see on 2D images. Sometimes LVOT obstruction is inherent to cardiac anatomy. Like in this case, even when the patient has concordant AV and VA connection, but since the patient had bilateral conus, this long subaortic conus led to narrowing of this LVOT. And this is sometimes what we call as anatomically corrected malposition of great arteries with left and anterior aorta. And if you see this video, this further clarifies why this patient is bound to develop LVOT obstruction at the time of detection, or maybe even after surgery, that this patient is likely to have LVOT obstruction. Now, catheterization is useful exant in select cases. So I'll go back to that index case where we had a subaortic membrane, severe LVOT obstruction, and associated PDA. As you can see over here, LV pressure is 300 as against aortic pressure of 130 with a gradient of 170. And I'm sure Dr. Sachin would be discussing later in his presentation how he dealt with this situation. So in such situation, cardiac catheterization provides useful information. CT angiography can provide, again, detailed analysis. As we can see over here, if we see, this is the LVOT area where this is the ring all around. And if you go further up, we can see that this further gets narrowed down and the aortic valve is normal. So this is how we can analyze on CT what we are seeing. If we do virtual dissection using newer tools and technologies, we can further identify how close is this membrane to the left coronary cusp. It's almost adhered to the left leaflet of the aortic valve, and that has implications during surgery. Now, this is complex LVOTO that warrants detailed assessment. And as we can see over here in multiplanar reconstruction, how this LVOT region is so narrow in different planes. And this, again, virtual dissection shows that this patient has a membrane as well as a narrow LVOT causing complex LVOT obstruction. Now, that was all about subvalvular aortic stenosis I wanted to talk. Now, coming to supravalvular aortic stenosis, it is the rarest form, mostly part of elastic cardiomyopathy, 3 types, hourglass, diaphragm, and then diffuse hypoplasia. As Dr. Vera clearly mentioned, that there is thickness of the aortic wall. In addition to the obstruction at this area, they also have valvular obstruction in nearly 1/3 patients. AR may be present in another 1/3. Peripheral pulmonary stenosis is common to the tune of 70 to 80%. Coronary abnormalities due to high pressure or due to leaflet adhesion or fibrosis may also be seen in a significant majority of patients. Arch branches may be involved. And more importantly, because of the thickened walls, they may have loss of wind castle effect and have hypertension and would maintain long-term follow-up even after surgery. Now, these are various indications for management of these patients. Few things which I want to highlight is that supravalvular aortic stenosis progresses faster than other LVOT obstructions, and there is the importance of meticulous close follow-up in these patients. Peripheral PS, fortunately, tend to regress over follow-up. Now, preoperative imaging, I think imaging also starts from photograph or looking at the patient, and this dysformism is very much classic of Williams syndrome. And once we see this, we know that the patient is likely to have pulmonary artery stenosis along with supravalvular aortic stenosis. I mean, these are two different types where there is a membrane at supravalvular region, or there can be hourglass deformity. Sometimes a familial homozygous hypercholesterolemia has almost a similar pattern, and they'll mimic like supravalvular aortic stenosis, but they will not have peripheral PS as in case of Williams or elastin. Again, the same thing I'll do here, a 7-year-old girl with concentric LVH, and if you focus over here, there is RVH as well, high gradients at LVOT origin. We look at turbulence starts way above aortic valve, and there is mild AR. Branch PS stenosis is there, but fortunately, the gradient is only 40. Normal arch vessels. Some of the unanswered questions are length of obstruction, extent of PA involvement, and coronary involvement, and that can be answered if we do a CT. As we can see on this patient, biventricular hypertrophy. Both coronaries are dilated. This is the right coronary artery. This is the left coronary artery, which is dilated. And then we are seeing that the arch, just below arch is formed, the aorta is normal. And these are the arch branches, which are normal. And this is 3D reconstruction of the same. As we can see that this is nearly localized obstruction. And this is the narrow lumen at that point. There are some of the more images which shows that valvular aortic stenosis may be associated. Innominate arteries may be involved, but few questions can only be answered by catheterization, like what is the hemodynamic severity of peripheral PS? Is it sufficient to treat supravalvular aortic stenosis alone? And in this case, as we saw that the MPA pressure was only 55, so we decided not to treat peripheral PS, and the patient was operated only for supravalvular AS with good surgical outcome. Now, these are some of the classic supravalvular AS images, and those who are cardiologists among the audience can see this typical trace of supravalvular aortic stenosis. This is classic peripheral PS, which is seen in Williams syndrome. Sometimes supravalvular AS may get complicated by infective endocarditis, and as you can see over here, this is outpouching from aorta. There is long stenosis in the aorta, and the process has also involved the brachiocephalic artery, and there is actually cut off because of infective endocarditis and vegetation. It can be quite devastating. As you can see over here, the whole of aorta is deformed with multiple outpouchings at different places. In these patients with supravalvular aortic stenosis, post-op imaging is very important. Like in this case, who was operated at the age of, I think, 4 years, had supravalvular AS with proximal LMCA stenosis, developed dilatation of the proximal aorta, and that's why we need to image these patients in the post-op period. So to summarize, echocardiography is the main imaging modality as far as subvalvular aortic stenosis goes. In supravalvular, it may not be sufficient. CT angiography permits high-quality cardiac imaging. CT-based virtual dissection provides enhanced 3D visualization. In select cases, cardiac catheterization clarifies hemodynamics, and insightful imaging is crucial for optical procedural planning. Thank you so much for patient hearing.
Well, thank you. That was a really outstanding talk. Those images are incredible that you have. Those cases that you've compiled are really very instructive. The question I have is, addressing supravalvular AS can sometimes be extremely satisfying to open this up with the different techniques that we're going to hear about today. But what becomes particularly disheartening to the surgeon is when you open things up and you see involvement of this fibrous sheath into the coronaries, whether this be a ridge guarding a coronary or that it actually extends into the coronaries. What tricks do you have And what are your thoughts on those cases? How do you like to image them? How do you counsel your surgeon? Whatever you can.
I think coronary involvement is something where we have to fall upon other things like ECG. So ECG is something which is very, very important and which is often neglected in the clinical setting. So if the patient, in addition to left ventricular hypertrophy, has STT changes with the strain, we have to seriously consider that there may be associated coronary involvement. Because even with the advancements in cardiac imaging, coronary is something which is not very well seen on any of the imaging modalities. So personally, I would suggest the surgeon that, see, I'm sure this much, but I still have some doubts left. So you have to be careful when you are repairing such a patient. And I want to give that information to the surgeon. But CT has improved a lot. And in most of the cases, we are able to say, but the certainty, I would say, is not 100%.
Thank you. And we have a question from the group regarding the resection of subaortic membranes. What kind of tricks do you have to assess the actual effect of the membrane on the cusp, or how aggressive to be about resecting the fibrous sheath off of a cusp of the aortic valve?
I think during echocardiography, we have to be very careful in looking at the valve motion, because what happens during assessment is, as soon as we find a trileaflet valve and a subvalvular membrane, our focus goes more on the membrane and we forget about the valvular motion. So even if a valve cusp is moving slightly lesser than the other cusp, it is highly indicative that we may be having lesions on the aortic valvular leaflet. So I think if that is there, we have to think that most likely the patient is having some kind of aortic valve involvement. Secondly, if AR is anything more than mild, I would consider that the aortic valve is involved. It's not always because of the orientation issue. It's mostly because of the aortic valvular involvement. I mean, surgeons can correct me because they see it on the table. That's what I have understood during my practice.
That's an excellent answer. Thank you so much. Thank you for the wonderful talk. I think we should go on to the next one.
Thank you.
Okay, thank you, Michael. That was a nice talk. Our third talk today is going to be delivered by Dr. Christian Pizarro from Wilmington, US. His talk is about surgical management of supravalvar aortic stenosis, surgical techniques, single patch, double patch, 3-patch, and autologous reconstruction. Please, Christian, go ahead.
Morning, I'm Dr. Pizarro from the Morphology Cardiac Center, and I'm going to speak this morning about the management of supravalvar aortic stenosis in the pediatric population. I have no disclosure. The term supravalvar aortic stenosis, it was really coined after a description of 5 cases by Creel in 1959. Creel and colleagues described the clinical features as well as the natural history of these patients. Of note, the average survival of this patient was 39 years of age, and all of them demonstrated significant left cardiac dilatation of left ventricular hypertrophy. As shown here in this picture, you can see the thickening as well as the neointima proliferation immediately at the side of the centrotubular junction, which restricts significantly the orifice of where the blood could pass into the sinus of Valsalva in order to establish coronary perfusion. In addition, you can see here there's some adhesions and bands that restrict that opening even more significantly. It wasn't until 1961 when Williams and subsequently Vera described the syndrome that it was related to a defect in the elastin gene in chromosome 7 due to a microdeletion, which also was associated with usual hallmarks of the arteriopathy plus an additional clinical features. There are 2 significant phenotypes for supravalvar aortic stenosis. This is familial and the Williams-Vera syndrome. The patients with the syndrome exhibit neurobehavioral, metabolic, endocrine, as well as craniofacial characteristics. As mentioned, the microdeletion in the chromosome 7 of the elastin gene is the hallmark, and cardiovascular disease is generally seen between 45 and 70% of these patients. It is highly variable in terms of the expression, and it ranges from an infantile presentation, which is usually associated with a more grave prognosis, and it goes to a broad spectrum, leaning also to patients who are apparently clinically without any involvement. Male sex factor is a hallmark and risk factor for early and presentation and severity of disease. In contradistinction, those patients with a familial form have no neurobehavioral issues, no metabolic, endocrine, or developmental features, or the craniofacial characteristics. And this is largely due to translocations and deletions at point mutations rather than a microdeletion. In terms of morphological types, there is a membranes type, which is exceedingly rare. It's generally semicircular membranes. Really, in histology, there's no medial elements, and sometimes there could be more than one membrane. And then there are the two most common forms, which is the hourglass deformity, also called discrete, and the diffuse form. Both of these share histologic features of disorganized architecture in the media, fragmented elastic fibers and focal clumping, and hypertrophy of a smooth muscle cell, and enlargement of the vasa vasorum. As you can see here, the discrete form shown in this pictorial, which sometimes could have direct compromise of the orifice of the coronary artery origin, and then the diffuse form, but generally it's affecting the ascending aorta, sometimes the arch, and many times the descending aorta, occasionally the abdominal segment of the aorta. In natural history, this has been well characterized by now. There's an original paper by Christopher Wren and Kate Bolt from the United Kingdom that demonstrated this is a process that generally doesn't go away. It's a progressive lesion. And their observations showed that the left ventricle to aorta pressure gradient had increased in most patients undergoing repeat cardiac catheterization, which was common in those days. Serial angiography showed that increased pressure gradient is related to the failure of the normal growth of the supravalvular aortic region. In contradistinction, the lesions on the right side, meaning the pulmonary arteries, seem to resolve over time, although they could be quite severe in early presentation. Preoperative evaluation in the past has been obviously at the moment of time of autopsy, and cardiac catheterization also was utilized. However, due to increased experience and the destabilizing nature of these procedures, the non-invasive form of echocardiography and other forms of axial imaging has been generally the gold standard in the modern era. Most patients really do not undergo exercise tests, considering the fact that there is a significant vulnerability for myocardial insufficiency, and therefore most of these patients are followed by non-invasive methods like Doppler measurements and echocardiogram in order to make the diagnosis. Axial imaging also helps follow the overall progression of the disease. However, it's important to note that many of these patients, being young, require sedation, and sedation becomes could be a very destabilizing intervention in these patients. Indications for innovation generally include surgery and the timing, which is very important, as you will see in a number of different series. The timing of surgery or intervention has become sooner and earlier in life now in the more recent decades compared to the original communications. The mean gradient by echo Doppler, which is generally utilized for this threshold, is 40 to 50 millimeters of mercury, mean gradient, not peak. And other indications will be compromise of coronary blood flow, either ECG changes, myocardial ischemia, or evidence of decreased function. In the forms that are diffuse, the presence of hypertension and aortic arch obstruction also constitute a significant indication for surgery. And then there are some cases that have associated conditions like valvular aortic stenosis, pulmonary stenosis, or subvalvar aortic stenosis. So what options do we have here to manage this? Well, historically, Magoon described a one sinus limited reconstruction in the early 60s. However, the challenge with this is that it does not eliminate the potential for coronary insufficiency. It uses heterologous patch material, which might lead to recurrent stenosis. And generally, those were cases that were reported much earlier in the literature and in much older patients. Subsequently, Doty described the inverted Y-shaped patch, which provide reconstruction of two sinuses. Also limited reconstruction, which does not eliminate the potential for coronary insufficiency on the left side and might lead to recurrent stenosis. And that was, described just about 15 years later. More recently, then Brom and colleagues described their technique of enlargement of three sinuses with three different patches, and then the modified Brom technique, which also can extend the patch to the ascending aorta and possibly the transverse arch. As you could see in this particular case, there are three incisions, and there are three separate patches, and one of those patches could extend into the ascending aorta. The most innovative technique was the one described by Luis Carlos Bento de Sousa and with the group of the Adib Jatain in the early 90s, earlier than this description by Dr. Myers, which was published in the English literature and then popularized. But the ones who really came with this concept were this group in Sao Paulo, Brazil, which is three incisions in each of the sinuses, and also counter incisions in the ascending aorta, and then advancement of the two ends, therefore doubling the overall cross-section and utilizing no heterologous patch. As you can see in the initial report, there were 4 patients that ranged from 1 to 38 years of age, and 3 of them had Williams-Byrne syndrome, and they had no mortality, which was a real, breakthrough in the management of these patients. And this is basically what is done, in a more contemporary cartoon. Native tissue only allows growth, and therefore the possibility for earlier repair. Enlargement of 3 sinuses eliminate all gradients and eliminate the impediment to coronary blood flow during diastole. And I think this is a very elegant cartoon by the group in Melbourne that really conceptualized how is it that coronary flow occurs in these patients. And after repair, you can see that there is a transition from a systolic flow to mostly diastolic flow, which is what we want to see. There are important considerations for recommendation of anesthesia in Williams syndrome, and the preoperative evaluation is extremely important. And obviously, these patients are at increased risk of sudden death or sudden events, and therefore that should be recognized and considered at the time of deciding which diagnostic tool to use. This is a group from Paris that showed overall reconstruction in comparison with one patch repair versus Doty repair and Brom repair. And as you can see, there is a substantial increase in the overall improvement in the results with the Brom repair, which is 3 patches and 3 sinuses with a much lower grading. As you can see that the overall incidence of aortic insufficiency in this also 3-patch technique appeared to be less. Similarly, it's in the group from Melbourne demonstrated that in the comparison of Doty repair, which is 2 sinuses versus 3 sinuses, there's a substantial improvement in the overall survival, as well as freedom from reoperations in this group of patients, for a total number of 28 patients in this cohort with a follow-up of 5 years. Subsequently, the group from the Netherlands and Mark Hazenkamp has demonstrated that in one of the longest follow-up studies with 100% complete follow-up at almost 20 years, they lump or categorize the repairs into non-symmetrical versus symmetrical 3 sinuses. And as you can see, there were 5 of 8 deaths at a repair at greater than 10 years of age, so late repairs, and 4 to 6 late deaths were sudden. And their striking finding was the survival was remarkably low. And most common procedure for reoperation was aortic valve replacement. The study from the European Association of Congenital Surgeons showed that they had a median follow-up of 13 years and late death of about 5% and 12% of reoperation. And this most common reoperation was aortic arch repair. They showed no differences between techniques. However, patient factors were more important than the overall technique itself. Similarly, adverse cardiac events in patients with Williams syndrome, and a study from the analysis of the SDS congenital database demonstrated that, generally speaking, demographic characteristics overall for the Supravalvar Aortic Stenosis the odds ratio where the any preoperative risk factors and previous cardiac surgery were almost double the overall risk in general, as you can see. And when we looked at hospital mortality, is lower in the isolated form compared to the complex forms, or the forms that have right and left compromise. So in summary, supravalvular aortic stenosis is a very challenging condition. There's delicate equilibrium of coronary perfusion, the risk for acute myocardial event, ischemia, arrhythmias, and arrest. Non-invasive assessment is preferred. Several surgical techniques from one autologous patch to three sinus reconstruction are available. The advantage of this last one is the growth potential. There's no clear evidence of superior surgical technique as of now. Coronary arterioplasty should be performed in selected cases when there is compromise of the ostia of the coronary artery, most commonly the left. Diffuse forms require extensive reconstruction and carry worse prognosis, and there is significant late morbidity and mortality, which mandates overall surveillance. I'll be happy to answer any questions, and thank you for the opportunity to participate in this forum.
All right, we have several questions. Thank you so much, Christian. That was an excellent, really great talk. And I guess I'm interested up front on your selective intervention on the coronaries. Can you shed any light on how you make decisions to go after coronary involvement?
Thank you, Mike. I think that the issue of the coronaries, and I want to echo and thoughts of the first speaker, is the fact that it's very difficult to be absolutely certain that there is no coronary compromise, and therefore we treat every patient as if there is possibility for it. And I think that that should be something that we plan. The studies, diagnostic studies that require sedation, should be done with expert people, ideally expert cardiac anesthesiologists, backup. Everybody's aware of what's happening, because these patients, particularly the youngest patients, they are a little bit of like a time bomb, which is where it's completely unpredictable. And therefore, we treat everyone as if there is a coronary obstruction. We induce anesthesia with perfusion ready, blood in the pump or in the room. Surgeons, just about ready to scrub, and the table all prepped. And then certainly there are patients who do have an issue with coronary obstruction, particularly ostia, but it's been my observation that for the most part, those patients do have a fair amount of restriction at the level of the opening of that sinus valsalva, where the tissue overgrowth is sort of like an overhang, and between that and the leaflet itself, that's what creates most of the obstruction. And if you resect that tissue, particularly if you do a 3 sinus reconstruction, you are able to really eliminate that problem altogether. And I certainly, my experience is limited because these patients don't come very often, but I yet have to see a patient where I've had to patch a coronary artery using this particular technique.
The question from the audience is, do you think, because of the risks of cath inherent in these patients, how do you feel about just recommending CT scan, CT angio these days?
I think that the CT angio gives you nice pictures, undoubtedly. Personally, I wouldn't treat the patient any differently regarding of whatever they tell me, because I think that you and I and most of the people in this audience have been at some of this present your catastrophe at a surgical meeting, and it's the patient who have supravalvular AS that went to the OR, and anesthesia was inducing the patient arrest. And then that's the other point that I think that the group, Igor, I believe in this paper from Melbourne, described the fact that there's a very important observations that this patient needs to come off a pump with a relatively high perfusion pressure. And every time you lower the pressure to what would be at the standard, then the patient will tend to fibrillate. And that becomes a very destabilizing move. And I think that that's the other thing that the other variable that is not really mentioned very commonly is the fact that myocardial protection is extraordinarily important in these patients, and perfusion pressure after the surgery is also extraordinarily important. And given the fact that the lesions on the left side are progressive and will not go away, but rather become worse. Our threshold, generally speaking, has been to move to surgery sooner rather than later and go for autologous 3 sinus repair, which would allow for growth. And therefore you eliminate the potential issue that heterologous patch material will become restrictive over time.
And since you perform the autologous preferentially, it sounds like, can you explain to the group where you make your cuts relative to the coronaries when you're doing that autologous advancement? Sure.
So I think that the first cut is where the hourglass, the narrowest spot of the hourglass deformity is, which is generally speaking, you know, just at the level of the sinotubular junction, and you got to be very careful not to get the commissure. So if you see the hourglass deformity, err on the distal side of where it starts opening up rather than in the middle or in the proximal side. So that keeps you away from the commissure. And once we get that, we cut directly and deep into the non-coronary sinus. And now you open that as like a book, and now you have the left and the right sinus in front of you, and then you could, you know, much more selectively and with much better vision, you know, make that cut. And depending on the position of the coronaries, we generally tend to be higher than the normal, correct? Then you make your incision right or left of the coronary, depending where that coronary sits in the sinus itself, and obviously excise with, you know, sharp scissors all that tissue overhang that is basically creating this sort of, you know, overhang or drift, if you will, that when the coronary comes here, it nearly obliterates that. That's basically the way we do it. But I think the key is to open the non-coronary sinus first, and that will really allow you perfect visualization of the remaining of the other 2 sinuses that contain the coronary.
Well, that was an excellent talk, great discussion. There are many more questions, but I think we need to move on to the next speaker. Thank you.
Thank you. Thank you for the opportunity.
Well, that was an excellent talk. So our 4th talk today is going to be delivered by Dr. Igor Konstantinov from Melbourne, Australia. His talk is about the supravalvar aortic stenosis with the aortic arch and pulmonary artery involvement. Please, Dr. Konstantinov, go ahead.
Thank you. Well, basically, briefly touch on definitions first. In Melbourne, we would like to see those narrowings in aorta as 2 types. Type 1 is generally local at ST junction. Usually it is not a problem. We all know how to deal with this limited supravalvular stenosis. Type 2 is where the problems are. And it is more diffuse, if you wish to call it diffuse, that involves ascending aorta. And the main pulmonary artery involvement could be in both. And again, easy to deal with. But in diffuse pulmonary artery involvement, it is much more of a problem. And when we talk about diffuse, we essentially talk about Williams syndrome. This is what happens in Williams syndrome. So in Melbourne, we published this paper in 2015, looking at our techniques and how we deal with Williams syndrome. And essentially, we used 3 techniques: Magoon, Doty, and broom technique. As you see here, we had 28 patients over a period of 30 years. And the technique that we use all the time now for the last 10 years or so, it is extended 3-patch techniques. And I use this patch from non-coronary sinus that extends quite fine to the ascending aorta. And it looks at it gives symmetrical enlargement, and we're very happy with this technique. In Williams syndrome patients, they often have involvement of main pulmonary artery, branch pulmonary arteries, and aorta. And if you look at our study, we had 28 patients, which doesn't seem a lot. But of course, we have more patients with supraaortic stenosis, which do not have Williams syndrome. And it is usually not a big problem. And similarly, others, if you look at what they published during the same period of time, patients with Williams syndrome, they constitute smaller proportion of overall patients. Well, and there were no deaths in 3-patch repair. There were no operative deaths. And I want to emphasize, as Christian just said, that Williams syndrome patients, they have progressive disease, and this is a problem. Patients die late. So we had 4 late deaths. And when you look at the deaths, very characteristics. Patient 1, supravalvular stenosis, main pulmonary artery patching at the age of 3 months. 3 weeks later, readmitted, had seizures, cardiac arrest. So whenever they have cardiac arrest, it's ischemic, it's coronary artery until proven otherwise. There are no other reasons for cardiac arrest. Patient 2, supravalvular aortic stenosis repair at the age of 4 years. At 11 years, aortic valve replacement. At 20 years, bent Alcorno, mitral valve repair, postoperative cardiac arrest, ECMO, brain death. Patient 3, supravalvular aortic stenosis, sudden death, 4 years. Whenever people say that somebody has sudden death in Williams syndrome, in my mind, it's coronary malperfusion. Patient 4, supravalvular aortic stenosis, MPA patching at 18 months, then patching of innominate artery and aortic arch at 5 years, could not be weaned off ECMO. Again, it looks to me that coronary perfusion. And the 3-patch technique gave better result, but again, it was because of era effect and a small number of patients, no meaningful statistics could be done here. Reoperations, again, they all happened in Doty repairs, and they involved enlargement of aortic arch, and it tells us that this is progressive disease. Well, how do we deal with aortic arch? This is a picture from my recent paper on transplantation in univentricular hearts. But just to emphasize how we manage perfusion, ideally, if femoral arteries are good size, it's nice to put a graft on the femoral artery and have descending aorta perfusion. I cannulate aorta, and then I introduce the aortic cannula into the innominate artery, so I have cerebral perfusion in the same time. I tend not to clamp descending aorta, but rather put a large Fogarty catheter there, and then I could repair aortic arch. We don't do replacement of aortic arch in Williams syndrome, but repair it. And this is specifically for Williams syndrome. Unfortunately, in the most recent patient that I did, femoral arteries were very small, minute. It's not possible, just not possible to put graft or cannulate. So, and also I could not introduce the aortic cannula into innominate artery because of quite severe proximal stenosis. So what I did here for perfusion, number one, I cannulated with a smaller cannula. I replaced aortic cannula after the patient was cooled down, and I cannulated the innominate artery high. So I had cerebral perfusion. And then I put this Fogarty catheter into descending aorta and connected it to aortic cannula with Y connector so that there was distal perfusion all the time. And then it basically patient had a whole body perfusion, and we could patch entire aortic arch and the arch vessels. This is an interesting patient I thought I will present. You see CT scan picture at 6 months of age, and it may look that I'm showing you a poor quality CT scan, but trust me, this is absolutely the very best picture of the pulmonary arteries that I could get on CT scan. So she was presented, discussed at 6 months of age, and everyone looked at those pulmonary arteries, which were diffusely small, and thought, well, the outcome is likely very poor, we should palliate, and the parents agreed to palliate. So this patient did not die, and did surprisingly well, and grew up, and at 5 years of age, presented with syncopal episodes. And supravalvular aortic stenosis mean pressure gradient was 58, pulmonary arteries were not seen by echo, and everyone saw that we should not do CT scan under sedation because the risk is too high of cardiac arrest in a CT scanner, which is, well, rightfully so. And at this time, parents changed their mind. They wanted everything to be done, this patient to be operated. Well, we took her to the operating room, and one point to emphasize, for every single patient with Williams syndrome and supraaortic stenosis that goes to the operating room, or for that sake, for any patient with supraaortic stenosis, before induction of anesthesia, our whole team is scrubbed and in the operating room. We never, ever, ever, ever induce anesthesia on anyone without our surgeon scrubbed and present. So this patient arrested on induction of anesthesia, we very promptly opened the chest and quickly put her on bypass. And then I did usual 3-patch technique for aorta, enlarged the innominate artery, and patched those minuscule pulmonary arteries hilum to hilum. Interestingly, distally, I could put reasonably sized Jaeger dilator, but they always bounce back inside the hilum because they were thick pulmonary arteries, so they bounce back. I could, yeah, and coming off bypass, the heart fibrillates. Now, the extremely important point is that whenever we come off bypass, we have to come up with high pressure. It's about 130, 140 systolic blood pressure coming off bypass to have coronary perfusion. Otherwise, the heart fibrillates in advanced disease. So, and the right ventricular pressure was suprasystemic. So I left her on ECMO, brought her to ICU, and came off ECMO on postoperative day 2. LA pressure was 10, and the right ventricular pressure was suprasystemic. The only way I could come off ECMO with a right ventricular systolic pressure of 150 millimeters of mercury. And I emphasized to everyone ad nauseum that this is fine, this is good, this is what we're gonna have. And as we all know, sometimes things happen in ICU, some people try to improve things. So in early morning of the same day, somebody saw that it's not good for the right ventricle to have pulmonary arterial pressure of 160. Why won't we help right ventricle a little bit and give a little bit of milrinone? So they gave milrinone, she arrested immediately. We rushed and we put her on ECMO quickly, but with this amount of hypertrophy, it was not possible to do proper CPR, even though we put her on ECMO literally within half an hour. That's what we do. We have rapid ECMO response. We put her on ECMO immediately. She was brain dead. Tragic case. But I think that it's much better to present tragic cases because people learn from it than to talk about your successes. So finally, this picture that we previously published, again, this is a notion, this is a feeling what's happening. There is no way to prove or disprove it scientifically or do study, research of some sort. But what we thought that probably, well, I should start saying that normally 70% of coronary perfusion happens in diastole, but about 30% still happens in systole. It's a very interesting phenomenon. There is coronary perfusion in normal heart, in systole as well. So we suspect that in Williams syndrome, in severe supraaortic stenosis, there is quite significant systolic component, and they rely on this systolic component. Once we relieve supraaortic stenosis, those thick coronary arteries need to be perfused with much higher diastolic pressure, and we'll see it again and again when we try to come off bypass. The heart fibrillates if the blood pressure is below 100. Not always, of course, not always, but it's typically happening. So the high perfusion pressure could not be emphasized. And so in conclusion, surgical repair of supravalvular aortic stenosis has excellent early results. Most of the time, it's excellent early results. But despite these good early results, late mortality and reoperation rate are very significant. And diffuse branch pulmonary artery stenosis narrowing beyond ST junction in aorta is generally associated with poor prognosis because it's a spectrum of bad disease and it is progressive disease. Thank you so much.
Well, Igor, thank you so much for that presentation. I mean, you to present cases that don't go well, as you highlighted, is very instructive to everyone. And we've all seen these cases that just are not satisfying. One of the questions I have for you, because you really emphasized this point during your talk, the notion that 70% or 30% of perfusion occurs during systole, and that you have to maintain a very high blood pressure in these patients to get them off bypass or to get them off ECMO, or to just survive in the postoperative period if it's really severe disease. It raises the question of whether our goal of surgery should be to achieve a complete relief of all obstruction, or is there some kind of protective effect? You know, the patient survived to 5 years of age with this aortopathy, the obstructed aortic supravalvar aortic stenosis. Are we hurting the patient by achieving a perfect result in relieving all of that obstruction?
Well, it is certainly a very good thought-provoking question. I don't know the answer to it. Intuitively, I would say, yes, we should continue to relieve obstruction. This is what we do. Yes, I would say that we should relieve the obstruction, but I think that we need to be very cautious with blood pressure and make sure that we do not lower it aggressively and allow high blood pressure in postoperative period with the hope that maybe it will gradually balances itself. But it's really difficult to say that we should not relieve the obstruction completely. For surgeons, as you know, it's difficult not to try to do perfect surgery.
Right.
But it's a very good thought, yeah.
The question from the group that comes up, and you've used a lot of patch material, is what is your favorite type of patch material? What should we be using in these cases?
Well, we either use autologous pericardium. I used it quite a lot, but now most of the time we use CardioSeal, which is treated bovine pericardium.
Okay, well, thank you so much, Igor. I think we'll proceed with the next talk now.
No, that is my pleasure. Thank you.
Okay, so to move on with the program, next talk is going to be delivered by Dr. Hartzell Schaff from Rochester, US. He will talk about surgical management of hypertrophic obstructive cardiomyopathy. Please, Hartzell, go ahead.
Thank you for the opportunity of presenting today. I'd like to focus on what I believe are the keys to achieving optimal results of myectomy for HCM in children. And this involves understanding the phenotypes of the disease, as well as the surgical methods and exposure. And finally, I'll review some of our recent data on the outcomes of myectomy in children and compare this to the results of membranectomy for subaortic stenosis. Planning the operation involves some understanding of septal morphology, and we like to divide the septum into 3 zones. Zone 1 is the immediate subaortic septum. Zone 2 involves that portion of the septum just beyond the tip of the anterior leaf of the mitral valve out to the papillary muscles. So this would be Zone 1 and Zone 2 obstruction, what we consider a long segment of septal obstruction. And in some patients, the septal hypertrophy extends to the distal portion of the ventricle. Patients who have severe hypertrophy in the distal portion of the ventricle may have a small ventricular cavity and require an apical myectomy to enlarge the left ventricle at the time of subaortic myectomy. These echoes show the examples of Zone 1 and Zone 2. On the left, you can see the patient has isolated basal septal hypertrophy. The patient on the right has systolic anterior motion, but the septal hypertrophy extends to the papillary muscles. So this patient will require midventricular myectomy as well as a subaortic myectomy. This patient has hypertrophy in all 3 zones of the septum. There's subaortic obstruction due to basal septal hypertrophy, but also hypertrophy of the midseptum and distal septum, resulting in a small LV cavity. So this patient has diastolic dysfunction due to small LV cavity, as well as subaortic obstruction. One word about incisions. This young girl had a myectomy elsewhere and had recurrent obstruction. And you can tell from the site of the sternal incision why the surgeon had difficulty doing the operation. If you keep the incision low, you have very poor exposure of the subaortic septum. And so a myectomy is not a procedure that's easily done through a minimally invasive approach, at least through the midline. In addition to echocardiography during surgery, we think it's very important to measure intracardiac pressures. These are typical pressure tracings of a patient who had a resting gradient of over 120 millimeters of mercury. And after a PVC, that gradient increased to almost 200 millimeters of mercury. And with an adequate myectomy, we would expect the post-bypass gradient, both at rest and after a PVC, to be less than 5 to 10 millimeters of mercury. An important point in the operation is carrying the aortotomy to the base of the non-coronary sinus. Don't try to do this operation through a transverse aortotomy, rather use an oblique aortotomy. After exposure of the septum, we make an incision just to the right of the nadir of the right aortic sinus. This incision is carried up to the hinge point of the right cusp and then carried leftward over to the anterior leaflet of the mitral valve. In our opinion, it's unnecessary to go further to the right. That only invites additional potential injury to the left bundle. But if you carry the incision leftward, then you improve the exposure of the distal ventricle, as we'll show. This is what we call the first cut. The surgeon's guided by the contact lesion on the septum, the contact lesion from the anterior leaflet of the mitral valve, And after removing this first piece of muscle, the myectomy may look adequate as you examine it through the aorta. But it's important to carry the myectomy far enough towards the apex of the ventricle to completely relieve the obstruction. And to do this, we have the assistant use a sponge stick to rotate the septum posteriorly so that you bring the distal septum into view. Now, if you only remember one slide from the presentation, this is the most important one, because it shows a patient who was referred to us after having a myectomy elsewhere. And you can see from the echocardiogram on the right that the surgeon who did the first operation did a septal myectomy in the immediate subaortic area, but did not carry it down far enough to eliminate systolic anterior motion of the mitral valve. In other words, he or she didn't do that second cut. The second most common cause for residual obstruction is failure to recognize that midventricular obstruction. This patient was referred for redo myectomy after having an adequate subaortic myectomy. Notice on the right, there's no systolic anterior motion of the mitral valve, but there's midventricular obstruction. This is the zone 2 that we talked about before. And for a patient like this, we would approach this through the apex of the heart. There's no arbitrary depth that has to be removed from the septum during myectomy. This is a young patient who had a septal thickness of 12 millimeters, but had systolic anterior motion. And you can see that the post-myectomy septal thickness is 8 millimeters and there is no SAM. And when we look at the relationship between septal thickness and complications, including VSD and mortality, we see that there's really no strong correlation between the thickness of the septum and outcomes. An anomalous papillary muscle inserting into the body, the anterior leaflet, can contribute to outflow tract obstruction, as shown here. We first used transapical incisions to enlarge the left ventricular cavity, but it's a very useful approach for patients with long segment subaortic obstruction, such as those patients who have hypertrophy in zone 2. And it's also helpful for patients who have a small LV cavity in addition to subaortic obstruction. So in these patients, we would do both subaortic and transapical myectomy. This is a patient with pure midventricular obstruction. You can see there's no systolic anterior motion of the mitral valve, and the flow acceleration is in the midventricle. We prefer to approach these through an apical ventriculotomy, and here you can see that the resection is guided by the endocardial scar, just as you have the anterior leaflet touching the septum in subaortic obstruction. Here you see the papillary muscle contacting the midventricular septum, and that guides excision. The increasing use of transapical myectomy may reflect the practice patterns in our referral base, but you can see about half of the patients have a transapical myectomy only, and the other half have a transapical myectomy in addition to a subaortic myectomy. We've done this operation in 320 patients through 2019. If we include the pandemic years, I'm sure it's well over 400 patients. What about late outcomes? In this analysis, we compared the late survival of children with hypertrophic cardiomyopathy who underwent myectomy to children who underwent membranectomy for simple subaortic stenosis. The patients with HCM are shown in red, and as you can see, the survival is quite similar through the first decade. But after the first 10 years postoperatively, there is some diminution in survival of patients with HCM, and the difference was statistically significant over the 20-year follow-up period. One possible explanation for the difference in late survival would be the need for reoperation due to another cardiac problem or perhaps to recurrent obstruction. But as you can see here, the incidence of reoperation for any cause was over twice as high in patients who had membranectomy for subaortic stenosis compared to those who had hypertrophic cardiomyopathy. And because the patients with hypertrophic cardiomyopathy were slightly older at the time of operation, we then adjusted for age, and even after this age weighting, there was still a significant difference in need for reoperation late after membranectomy compared to myectomy for hypertrophic cardiomyopathy. And if we look at the incidence of reoperation just due to recurrent LVOT obstruction, we see that this incidence was again twice as high in children who had subaortic stenosis compared to those who had myectomy for HCM. I should note that we did not find an association in patients with subaortic stenosis between the addition of a myectomy at the time of membranectomy. The risks were about the same in terms of recurrent obstruction. So children with hypertrophic cardiomyopathy who undergo myectomy have a somewhat reduced survival, but it's not due to recurrent obstruction or need for reoperation. I'll stop here. I'm sorry we didn't have a chance to talk about alternate procedures for children with hypertrophic cardiomyopathy or about associated right ventricular outflow tract obstruction, but perhaps we can in a discussion. Thank you.
Well, thank you so much, Dr. Schaff. That was just an amazing, I mean, your experience is incredible with this lesion. And what strikes me is that with all of those 400 cases, you still emphasize approaching zone 2 through an apical incision, where I would have thought that with more and more experience, you would lean towards tackling more of those through the aorta. So that's really, that says something about this approach. So I guess my two questions are, number one, are there cases where you address zone 2 resections through the aorta? And secondly, what tips do you have for making a safe apical incision, avoiding papillary muscles, and any particular tricks?
Yeah, that's a good point. It certainly is a continuum. So there are many patients with long segment septal obstruction that we would do a transapical myectomy, carry the resection as far as we can through the ventricle, close the aorta, come off bypass, and see if there's residual SAM. So if you're able to get it through the aorta, it's unnecessary to go through the apex. But I think as we look at patients that come back with recurrent obstruction, it's that more distal portion of the septum. And so we really have or at least I have a low threshold for going through the apex if the post-bypass echo shows residual SAM and obstruction. Now, one point about the transapical incision and where you place it, it's if you have apical hypertrophic cardiomyopathy and you're doing the operation to enlarge the ventricle, you do have to be quite careful at the initial apical incision because papillary muscles are apically displaced in that condition. If it's simple mid-ventricular obstruction, you can easily avoid the papillary muscles, but be very careful in the apical cases.
Thank you. That's great. And a question from our group is about a transmitral approach. Do you have thoughts on when you would apply that?
Yeah, in very small children, you might consider taking down the anterior leaf of the mitral valve and doing a myectomy through the left atrium, and that's been done at our place. Personally, I think if I saw a patient that I could not do the adequate myectomy through the aorta, I would go through the apex and do the septal myectomy that way rather than taking down the anterior leaf of the mitral valve. I know there are some surgeons who are enthusiastic about this approach, but you do risk injury to the mitral valve and risk recurrent mitral regurgitation if your repair is not secure.
And one final question, how do you manage these patients in terms of medical treatment before surgery? When do you decide to operate? And then how do you manage them after the surgery? Anything special from the medical management side?
Well, it's a little different for children and adults. I mean, the standard line for medical management in adults is that you treat them with beta blockers and calcium channel blockers and perhaps with disopyramide until they either have side effects from the drugs or they have persistent symptoms. Children are a little more difficult because they often limit their own activities, but you can't, it's more difficult to treat them with medication in terms of compliance, but it's also more difficult to manage their activities. And sometimes children are referred for operation who have relatively few symptoms, but you want to be able to allow them to maintain their normal activities and participate in competitive sports and that sort of thing. So it's different for children. I would guess we maybe have a lower threshold if a patient has a very high gradient in a child to go ahead with surgery compared to an adult.
Well, thank you so much for that talk. We're so lucky to have your experience, and your talk was so clear that you really provided a lot of technical information about how to do this. So thank you.
Thank you.
Okay, so we're going to move with the program. Our next speaker is Dr. Sachin Talwar from New Delhi, India. His talk is about a subvalvar aortic stenosis, surgical management of subaortic membrane. Please, Dr. Talwar.
Good evening to all in different parts of the world, and I thank the World Society for the kind invitation to present our experience. Okay, I have no disclosures to make. Presentation outline, what is this subaortic membrane? How do these patients present? I will omit this part. And why to operate on these patients, when to operate, then what is the decision making and choice of the procedure, then what is the surgical technique, and what are the early and the long-term results. So what is it? It constitutes around 70% of the patients with the LVOT obstructions. It is characterized by a thin fibromuscular diaphragm is found along this space between the anterior mitral leaflet and the bottom of the aortic valve leaflets, and typically forms a concentric or circular extension from the area of the aortomitral fibrous continuing towards the interventricular septum. The aortic valve commonly is tricuspid or bicuspid. However, it can have diffuse cuspal thinning, and if there is aortic regurgitation and a long-standing subaortic membrane, you tend to have varying degrees of aortic regurgitation. And then if the subvalvar and supravalvar AS is associated, then it forms a part of the spectrum hypoplastic left heart Neschon's complex. The left ventricle tends to be hypertrophic, often severely. There are varying degrees of subendocardial ischemia and fibrosis, and there is thickening of the left ventricular posterior wall and muscle fiber degeneration. And there are a lot of coexisting abnormalities, and I will not discuss these anomalies. Then why to operate? One of the important things which has to be kept in mind is the development of aortic regurgitation. So if the aortic regurgitation develops at any stage in a patient's natural history, then it is an indication to operate. Then left untreated, these patients tend to develop left ventricular dysfunction, which can be severe once the gradients progress. And there is a risk of possible infective enterocarditis. What is the timing of the operation? So in patients with mild subaortic stenosis, one should evaluate every 6 months, and the early surgery is required if the disease is progressive and there is development of aortic regurgitation. In patients with moderate gradients, the elective surgery is performed, and in patients who have severe gradients more than 100 millimeters of mercury, the immediate surgery is warranted. The selection of the procedures, the various factors that will be kept in mind are the type of the obstruction, whether it is localized or tunnel type. What is the status of the aortic valve? I will not be talking about the tunnel stenosis because the next speakers will be talking about it. The need for the root enlargement, the levels of the LVO2, and the age of the patient. Then I will be concentrating on the excision and myectomy as the treatment choices for the subaortic membrane, as the subsequent few options will be covered by the next few speakers. Then the excision is the choice of surgical amendment for subaortic membrane in patients in whom the aortic valve is normal and the aortic annulus is normal, and the Ross-Cono kind of an repair is reserved for those patients who have got the localized subvalvular severe aortic stenosis, AR requiring AVR, and for patients with normal left ventricular to aorta junction. Now, this cartoon is very important to remember to prevent the complications during the operation. As you see that this is the area of the membranous septum, and below that is located the left bundle branch block. So any area between the right coronary cusp and the non-coronary cusp is an hazardous area, because there's a very high risk of development of the complete heart block. And also the area of the membranous septum is normally thin. So it is very easy to produce an iatrogenic ventricular septal defect, especially if the aggression, if the resection tends to be aggressive. So the important thing is the conduct of the bypass. The aortic cannulation should be high so that you have access to the entire aorta. The venous cannulation could be single or bicaval. I personally prefer to do a bicaval cannulation, because in case there is an iatrogenic VSD, which has happened to me a couple of times, then the air doesn't trap the venous line. And then the bypass strategy could be mild or moderate hypothermia, depending on the surgeon preference. The myocardial protection is very important in these patients, because the ventricles are severely hypertrophied. And also, as indicated by the previous speaker, you need to know the details of the coronary arteries so that the myocardial protection does not suffer. The cardioplegia could be cold-blooded cardioplegia or crystalloid, again, depending on the surgeon preference. If there is no aortic regurgitation, then one could give root cardioplegia. But if patients have the severe aortic regurgitation, then you need to go for a direct ostial cardioplegia. And many surgeons, especially in the adult patients, would go for a retrograde cardioplegia. So left ventricular venting is also very important to prevent the left ventricular distension, which can produce the subendocardial ischemia. And if you prefer prior to the application of the aortic cross clamp, then you could vent the pulmonary artery, or after the application of the aortic cross clamp, you could vent the right superior pulmonary vein. I personally prefer to vent the ventricle through the right superior pulmonary vein and with a side arm of the left ventricle vent clamp, and I still am able to vent with the heart beating. And it's preferable to have a vent in place before the cooling is initiated so that the heart doesn't fibrillate. This is a diagram which shows how the aortotomy is performed, and it is an oblique aortotomy which is carried to the non-coronary sinus, and it can be extended obliquely across the sinusoidal junction to the non-coronary sinus for maximum exposure, and the extension into the AML is possible for posterior enlargement. But one should be careful that the sinusoidal junction is not deformed, otherwise you can have the aortic regurgitation. And in some patients, the transection of the aorta may be useful, especially if the intervention is performed on the aortic valve. And this is the cartoon which shows the judicious application of the stay sutures. Now, three stay sutures are put at the aortic commissures, and if you'll note that this is the nodular ornithine of the aortic valve cusps, and I tend to take 6 operating sutures which are developed, and then they emerge out of the aortic valve, and these tend to retract the aortic cusp nicely, and the assistant doesn't have to use any form of retractor which has the possible potential to damage the aortic valve leaflets. Then following this, the plane of dissection is developed between the ventricular septum and the membrane, and gradually the membrane is started to be peeled off as you approach the left coronary cusp. And once that is done, the membrane is gradually peeled off, and after it is peeled off, then a wedge of the muscle under the right and the left intercoronary commissure is excised with the extension under the left half of the right coronary cusp. And it has always been our policy to perform an aggressive resection, aggressive myectomy to prevent the recurrent obstruction. So I would be now presenting a patient who was 15 years of age, who came very late, and this patient came with a severe subaortic stenosis secondary to a subaortic membrane As you see, his LV pressure is 300 and the aortic pressure is 130 or so. So the gradient is around 130 across the LVOT. And this is the cath of this patient, the angiogram. And you can see that there is a negative shadow here, which shows the isolated discrete subaortic membrane. And this is the left anterior oblique view, which also shows that the membrane is present just below the aortic valve. So we had another injection with selectively profiled the coronary arteries, and with that I have omitted, but that's a very, very important projection to see. So this is the intra-trans-esophageal echo, and this clearly shows that a membrane is present below the aortic valve and there is no aortic regurgitation. So this is how the operation, oh, what happened here? Somehow we move to the end of, yeah, okay. So this is the trans-esophageal echo, which shows a peak gradient of 160 milliliters of mercury across the left ventricular outflow tract. Now, this is the start of the operation. As Dr. Schaff pointed out, a large incision, long incision, marking the aortotomy prior to initiation of cardiopulmonary bypass, because once the bypass is initiated, then the aorta tends to get collapsed. This is a huge patent ductus arteriosus that was present in this patient. The left ventricle being vented to the right superior pulmonary vein. As you see, it is being done on a full heart, so the air doesn't go into the cardiac chambers. Once this is done, then the aorta will be cross-clamped. The cardioplegia will be delivered, and having delivered the cardioplegia, an aortotomy is made on the site that has been previously marked. And this aortotomy is now extended into the non-coronary sinus, but it should be above the sinotubular junctions so the aortic sinuses are not distorted. Now, having done an appropriate aortotomy, now the stay sutures are applied, and these are the stay sutures at the commissures. And once we do that, the whole of the aortotomy gets pulled up, and now the aortic cusps are held. And then at the nodulus arenti, we will pass double arm 6-0 sutures, which will emerge out of the aortic wall so that you see the entire subaortic area. So these are the stay sutures that are being applied. And you can see that once these 3 stay sutures are applied, then that will give very nice exposure to the subaortic area. So this is at the nodular arenti of the right coronary cusps. So I'm particularly fond of this because that way you avoid the retractors completely. And then especially in smaller children, it avoids the damage to the aortic valve. So now the entire subaortic area has been exposed. And once having done that, the membrane which is here is identified. 2 pickups are used and a plane is developed between the membrane and the surrounding tissue, and gradually this peeling persists in an anti-clockwise direction. One has to be very patient with this because it is very easy to damage the structures. The underlying mitral valve is there. The aortic valve lines lies above this, so one can easily damage the aortic cusps and the mitral valve cusps. You can see that this membrane is extremely thick and tightly adherent to the aortic wall. And this is how the operation proceeds. And once we do hold this membrane up, and then having done that, we'll gradually incise this and take it off. So you see that a nice plane has been developed here, and the membrane is gradually coming off. And now we have come to the area of the anterior mitral leaflet, and the peeling has started. And once now we have got hold of the entire membrane, then this membrane is excised. once the excision is being performed, the care must be taken that you're away from the area of the conduction system. So that is the very sure shot way to get the patient into the complete heart block. So initially, it is a better policy to just peel off the membrane, and then after this is being done, then to go for the myectomy. So here you see that a part of the muscle is being resected, and that will be the myectomy. So I tend to be very aggressive with the myectomy because our previous experience has shown that once we do that, then it gives very good relief of the obstruction in long term. So now this is the entire ring of the subaortic membrane. This is the muscle, a wedge of the muscle that has been excised. The remainder of the membrane is then gradually peeled off, and again you can see that it is coming off the anterior mitral leaflet. And once you peel off the entire membrane, then you should be able to see the entire anterior mitral leaflet below this. So that is the anterior mitral leaflet here, and this is the left conventional sinus. This is the non-conventional sinus. That is the anterior mitral leaflet. So this is just to complete the excision of the membrane. And there you see again the intraoperative specimen. So now a generous myectomy between the right and the left coronary combination, and that extends way down into the cavity of the left ventricle. And as Dr. Schaff pointed out, this is going to extend almost down to the zone 2. I also tend, once having done the myectomy, I tend to size the left ventricular outflow tract. And before the operation, you get an idea of how much the left ventricular LVOT should look like. And I used the Hagar dilators to take a look. And in this patient, the acceptable size was 16. In a cardioplegic heart, it's better to go 2 sizes above. So we're able to put an 18 size Hagar dilator. And this is the post-operative the intra-op transispheric echo. And this shows the no aortic dilatation. The membrane is gone. The left ventricular outflow tract is cleaned out nicely. And then if we look at the monitors, once we came off bypass, you can see that this is the left ventricular pressure. This is the aortic pressure, and there is hardly any gradient across the. This is just a gradient of 8 millimeters of mercury as compared to the 180. And this is the Doppler trace across the LVOT. So the complications are the intraoperative complications. The whole deal of complications are possible. The common ones are damage to the aortic and the mitral cusps, which may need repair or replacement, and iatrogenic VSD or conduction abnormalities. Especially in the very early post-op phase, the conduction abnormalities are very, very common, but these tend to gradually settle down. However, if the complete heart block develops, then you always have a need for the pacemaker. The post-op abnormalities other than the heart blocker, the residual obstruction, the poor ventricular function. This is predominantly related to the improper myocardial protection, the development of the aortic or mitral regurgitation, again, which is iatrogenic. The VSD, which has been missed preoperatively because it tends to be associated very commonly with this condition, and the recurrence is another problem. And this is because of the regrowth which occurs from the scar site of the excision. So this is a cartoon which shows how close the mitral valve is to the aortic cusps, and it's very easy to inflict the damage. So if the mitral valve is damaged and the chorda tend to invariably get cut, so then you need to implant the valve, you need to put back the chorda into the mitral valve, and then you need to perform the septal myectomy again. So there's always a debate about the myectomy, why and why not. So The proponents of the routine myectomy argue that it gives good early and long-term relief. I will put a question mark on this because we really do not know, and whether it yes or no, that will always continue to be debated. The why not? Probably why not, because there's a almost 15 to 20% incidence of the complete heart block, and there are chances of an iatrogenic waste being produced. Now, this is our experience, which was published in 2001, and that had 45 patients. And we found that routine septal myectomy was associated with very, very low risk of recurrence. And only 3 patients had recurrent gradients out of 45. And the gradient tend to be very, very low. Still, it is less than 10 millimeters of mercury or so. And the characteristics of those patients who had gradients were presented below, and those patients who had significant gradients were those which had very, very high pre-op gradients. However, the gradients still continue to be insignificant, and one of these patients, who is this 8-year-old child, requires a conokind repair because of a small alveoli that has persisted. And this is the actuarial freedom from significant gradients, which you see at the median 15 years of follow-up is around 85%, and at 20 years of follow-up, it has still persisted to be 85%. If you see the fate of the aortic valve, in 21 patients, there was no air preoperatively, and in the 34 out of the 45, now there is no air. In those patients who had mild air, it has gone to become non-air. In those patients who had moderate or severe air, now only 4 patients have mild AR, and new aortic insufficiency has developed in 3 patients, and these patients have required aortic valve replacement. This is our new experience, which was published in 2017 with 146 patients, and the gradient was reduced to less than 20 millimeters of mercury immediately in the operating room, and freedom from reoperation at 25 years was 96.9%. This is the actual freedom from significant gradients was at 10 years of follow-up was 90%. And these are the features of those patients who had significant gradients following the surgery. And you see that at 15 years of follow-up, 5 patients tend to have a gradient of more than 30 millimeters of mercury. And these are those patients who are younger and in whom the gradients are very, very high to begin with. So if you see about the published data, this is the published data from the Chuck's Fraser group, and they say that the performance of a septal myectomy can minimize the risk of the reoperation. And similar observations have been encountered in a group for a sub-Saharan region who claim that an aggressive myectomy is very important because it avoids a reoperation in those countries, specifically where these patients cannot afford a reoperation. If you see this data from the Stanford group, again, there is a very high tendency to very aggressive with the resection of the subaortic membrane, and a myectomy is routinely being performed. If, however, you look at the contrarily published data, this is the data with the older patients, and it shows that the myectomy has not been shown to have any additional benefits in these patients. These are around 313 patients at 4 centers, and this was published in the Circulation, and they said clearly that there is a higher risk of the complete heart block. Therefore, it should not be performed. So this is the only paper which clearly says that you should not perform a myectomy. And this is another paper which was published recently, and if they compared the 2 groups of these patients, those undergoing myectomy or those who are not, and they said the addition of the myectomy did not result in the low rates of reoperation. So you can probably dispense away with the routine myomectomy. And now if you see the latest data, now these are 2 groups of patients. This is the group which did have the myectomy, and this is the group which did not have the myectomy. And you can see that at last follow-up, the gradients are much less in those patients who had a myectomy compared to those groups of patients which did not have the myectomy. And this was a study which was published in the Journal of Thoracic and Cardiovascular Surgery, in whom it was encountered that patients with or without myectomy did not have any difference in the significant gradients. To conclude that the freedom from reoperation is very good following the resection of the subaortic membrane. And again, the addition of a routine myectomy is very important in these patients. Thank you very much, and any questions are welcome.
Thank you very much for that talk. It was excellent to see your trick on providing exposure. That was really neat. We're going to move on to the next talk just in the need for time, to save time. Thank you.
Okay, that was a great talk. Our next talk is Subvalvar Aortic Stenosis, reoperations for recurrent subaortic membranes, going to be delivered by Dr. Ignacio Lugones from Buenos Aires, Argentina. Please, Ignacio, go ahead.
Hi, it's a pleasure to be here. My name is Ignacio Lugones, and I will be talking about reoperations for recurrent subaortic membrane. Socrates once said that all I know is that I know nothing. And this is particularly true in this topic, because recurrence and reoperation are frequent complications despite adequate initial relief of the subaortic membrane. So there is no consensus on how to predict recurrence, how to prevent recurrence, or how to treat recurrence. So during the next 10 minutes, I will try to talk about how to identify the preoperative risks, how to provide parent counseling, how to prevent recurrence after the first operation, how to treat recurrence during the reoperation, and how to identify postoperative risk factors for recurrence and establish the frequent follow-up. A few words related to parent counseling. Just say there is risk of recurrence because we don't know even the real incidence of this complication. Regarding the risk factors for recurrence, I have developed a score which, well, it is not a score, it is a fake score, this mnemonic rule, which is called SM grade. I will try to show you this way to remember the risk factors associated to recurrence. S goes for syndromes, genetic syndromes, M goes for malformations, other cardiac malformations, the G is for preoperative gradient, R for reoperation, the A goes for aortoseptal angle, D for distance between the membrane and the aortic valve, and E for encroachment of the valve onto the membrane onto the valve leaflets. Regarding syndromes, patients who required reoperation had a higher incidence of underlying genetic disease, particularly of Shown syndrome or other chromosomal anomalies. Other cardiac malformations can increase the risk for the reintervention. In fact, in Boston, they have developed a prediction rule, which includes other left-sided heart lesions in its core, in this score. The preoperative gradient above 60 millimeters of mercury might be a risk factor for the intervention, but again, some groups have not found such association, so we are not sure about this factor. The R goes for reoperation because we know that a previous intracardiac operation might increase the risk for reoperation. In this graphic, we see that complex, which is defined as a discrete subaortic stenosis with a previous intracardiac operation, had a lower freedom from reoperation in time. The A goes for the angle. A steep angle has been associated to development of discrete subaortic stenosis, but rarely associated to recurrence that require reoperation. Besides that, an unfavorable anatomy has also been associated to recurrence that require reoperation. Among these factors are the posterior deviation of the outlet septum, the extension of the structures to the LVOT, the extraposition of the aorta, and some others. The D goes for distance. A distance shorter than 6 millimeters in systole between the lesion and the hinge point of the right coronary cusp has been associated to increased risk of reoperation. But again, this is not conclusive information, and there are papers that show that this angle is not associated to recurrence. Regarding the encroachment of the valve onto the membrane onto the valve leaflets, this malformation can increase the risk for the operation. As we see, there is a fibrous tissue which is adhered to the membrane, to the mitral valve, or to the aortic valve. But of course, again, there is no consensus regarding this variable. So with this mnemonic rule, you can intuitively, but of course not necessarily true, identify the risk factors of a patient. The higher the FAKE score, the higher the risk of the reoperation for recurrent subaortic membrane. We will talk about the intraoperative period. We will divide it in first operation, and we will talk about how to prevent recurrence, and we will try to explain you how to treat recurrence during the reoperation. On all operations, there are 4 variables that are very important, which are the age at the operation, the role of the membrane peeling, the role of myomectomy, and the role of fibrous trigon mobilization. Age at first operation is important. Most studies suggest that younger age is associated to recurrence that require reoperation, but this might be only reflecting the severity of the disease. And of course, there is no clear cutoff. Some studies put this cutoff at 2 years, some others do it at 5, and some others do it at 4. So we don't have a clear information regarding this variable. Those patients who require peeling of the membrane from the aortic or mitral valves during the first surgery are at greater risk of needing subsequent reoperation. The myomectomy implies a higher risk of AV block, but in fact, this is not clear. We don't know whether this is true or false because there are publications in which the myomectomy is performed routinely, but there is no incidence of AV block. So should we perform routine myomectomy? Well, for the first operation, we really don't know. There's a lot of information and many papers reflect this variable as associated to recurrence, but some others don't. So we really don't know. But it is important that, considering that myomectomy does not seem to increase the risk for reoperation, we should always perform it when the second chance of getting a second surgery is unpredictable. And that is particularly true in low-income countries. Regarding reoperation, should we perform routine myomectomy? Yes, because for the patients who had a previous cardiac operation, the concomitant myomectomy group had a significantly lower rate of recurrence. Which is the role of the fibrous trigons? And first, what are they? The right and left fibrous trigons act as hinge mechanisms between the aortic and the mitral valves, and they allow the subaortic curtain and the anterior mitral leaflet to move during the cardiac cycle and they cause a normal enlargement of the LVOT during systole. So malfunction of these structures can affect and generate gradient on the subaortic portion. Fibrosis can extend to the trigons and to the subaortic curtain. So surgical removal of the fibrous tissue from the trigons and the subaortic curtain can be regarded as a surgical option for treating these patients. As you can see in the picture, you see the removal of the fibrosis from the right trigon. A preoperative gradient, regarding postoperative gradient, we have to say some few words. A gradient more than 15 or 30, depending on the study, is probably associated to increased risk of reoperation. Others have described that probably the LVOT gradient change can be reflecting a risk of recurrence. But of course, again, this is not conclusive, and we haven't been able to associate this in a clear fashion. So, to summarize, during the preoperative evaluation, please identify possible risk for recurrence. The mnemonic rule is SM grade. For the first operation, try to wait to avoid a young age at the initial operation, but if the preoperative grade increases rapidly, go for surgery. Try to avoid peeling the subaortic membrane. Choose whether or not to perform a routine myomectomy. Make up your mind, but do it if the patient has a low chance of getting a second operation. And always consider fibrous trigon mobilization in certain cases. For the reoperation, always perform the myomectomy and consider trigon mobilization and other techniques that have not been mentioned here. At last, during postoperative evaluation, adjust follow-up to postoperative range. Thank you very much.
Thank you. That was an excellent talk. And so it was really excellent the way you had each of the slides referenced. A quick question from the audience to stay on track here. Would you recommend myectomy in all patients or only those with extreme angulation of the LV outflow tract? I think you're muted, Ignacio.
Tener el micrófono silenciado.
All right. Unfortunately, I guess we'll have to move on to the next talk. Thank you very much.
Okay, our next talk is going to be delivered by Dr. Kisaburo Sakamoto from Shizuoka, Japan. He will talk about tunnel subvalvar aortic stenosis, the role of the modified Kono operation, valve sparing. Please, Dr. Sakamoto, go ahead.
Thank you very much for your introduction. Could you please start my video? I have no disclosure. Kono operation had been developed by Dr. Kono as a valve replacement procedure for patients with congenital aortic stenosis associated with small aortic valve ring. And recently, the same Institute of Tokyo Women's Medical College reported the 20-year experience. The left ventricular outflow tract reoperation free was 92% at 20 years. The ejection fraction is preserved reasonably, and the conduction bundle branch block occurred on 20 to 30% patient. They concluded, Kono incision can secure sufficient left ventricular outflow tract and is a safe treatment for complex left ventricular outflow tract obstruction without deteriorating left ventricular ejection fraction. However, small children had difficulty to choose Kono operation because of the size of artificial valves and anticoagulation. Modified Kono operation had been developed by Dr. Curry for patients with tunnel subaortic stenosis with acceptable aortic valve as a new procedure of septoplasty for left ventricular outflow obstruction without aortic valve replacement. Dr. Bue reported their experience and outcome on the 11 patients with diffuse subaortic stenosis who had modified Kono procedure with aortic valve preservation in 1993. And Dr. Bue informed us the detailed concept and technique of valve sparing corner on the Journal of Operative Technique in Thoracic and Cardiovascular Surgery in 2014. After opening the ascending aorta on the right ventricular outflow tract, firstly, myectomy just beneath the aortic valve is performed through aortic valve. The coronal septotomy is made, together with taking special care on the biggest septal coronary artery and the conduction system. From now on, I show surgical anatomy for modified coronal procedure. A penetrating conduction band goes in the membranous septum under the commissure between right and non-coronary leaflets. A coronal septotomy is made between pulmonary valve and tricuspid valve with taking care of conduction tissue, and it goes to the anterior rim of septomarginal trabecular, taking care of not dividing it completely, because the first septal perforating coronary artery usually locate under the anterior rim in the muscle between right ventricle and left ventricle. Dr. Wu emphasized importance to release obstruction caused by mitral valve components. Anomalous caudal attachment and papillary muscle of mitral valve should be reasonably exercised with keeping mitral valve acceptable function. Finally, the enlarged left ventricular outflow is covered by expanded PTFE patch. Right ventricular outflow tract is reconstructed with keeping the acceptable size, sometimes with resecting the hypertrophied muscle, especially on the Noonan cases. Let's check the result and evaluation after a modified coronal operation in the initial experience of each institute. Mortality rate was low. All also reported an effective reduction in left ventricular outflow tract gradient and evaluated it to be effective even for severe fixed left ventricular outflow tract stenosis. However, 10 to 20% reoperation for recurrent stenosis may occur within 10 years. Complete atrioventricular block is one of the most important postoperative complications of the modified coronal procedure. However, some surgeons commented, if the ventricular septal incision is placed accurately, the postoperative AV block could be avoided. Although the cardiac function often seems to be impaired after the modified coronal procedure, there have so far been very few reports describing the cardiac function. Surrey and Creeks reported an initial postoperative decline and following stabilization with time by follow-up echo data. Schaff and Creeks reported the recovery of the ventricular function after coronal procedure is analogous to that seen after aortic valve replacement alone. Sakamoto and Creeks demonstrated it was important to prevent damage to the first septal branch of the left anterior descending coronary artery to maintain ventricular function. This slide shows the report from Dr. Bue's team about long-term result of the modified coronal procedure. In the objective, they commented, transaortic septal myectomy is the gold standard surgery in obstructive hypertrophic cardiomyopathy, but it is not optimal for children aged less than 5 years and with right ventricular outflow tract obstruction. We evaluate outcome with the modified O'Connor procedure in children with severe form of obstructive hypertrophic cardiomyopathy. They studied 79 consecutive children. Mean follow-up time was 6 ± 5.7 years, and survival without death and heart transplantation was 82% at 20 years. There was no reoperation for recurrent obstruction, and atrioventricular block have reduced recently. And they concluded the modified O'Connor procedure provided durable obstruction relief and good long-term survival in children with severe form of obstructive hypertrophic cardiomyopathy. I completely agree with this attractive conclusion. By the way, left ventricular outflow tract stenosis, it had wide variation from discrete membranous type to severe form with tunnel stenosis. Dr. Buell had the following comment in the journal. Extended transaortic septal myectomy provides satisfactory result. However, the procedure is associated with the increased risk of residual or recurrent obstruction and/or iatrogenic injury to the aortic and mitral valves. In younger children, the operation may be technically challenging because of the difficulty of exposure of the intraventricular region through a small aortic orifice. Limited visibility may yield to inadequate transaction at the mid-ventricular level or inability to address mitral valve anomalies. Well, if neonates and infants have both LVOT stenosis and worse opening diseased aortic valve, how can we do? Original Conno, Ross Conno, univentricular strategy with node dams, or other choices? Before ending, I show my recent approach for critical aortic stenosis. Her age and body weight were 2 months old and 3.8 kilo. The valve had unicommissure type critical aortic stenosis with one not so bad commissure and the other almost zero height raphe. That seemed to be difficult to make reasonable commissuratory. I performed commissure reconstruction using 3 minutes glutarized treated autologous pericardium using open sleeve technique to get a better operative field, together with myectomy to subvalvar muscular stenosis. The early postoperative course was good. She has grown up well to 4 years old now, and the aortic valve has mild stenosis and mild regurgitation so far. The open sleeve incision can let go into upper part of the septum, and it can make a good operative field to release LVOT stenosis even on neonates and infants. I consider now this can be one of choice for difficult patients with both LVOT stenosis and worse opening diseased aortic valve. Thank you for your kind attention.
Thank you very much for that talk. We have 2 questions. The first is, when you're doing this valve sparing modified Kono, how do you make a decision that it's adequate and when or inadequate, and you need to convert to sacrificing the valve and doing a traditional cono?
Yeah, very difficult to make answer, because the size of the aortic valve is very important to make a good operative field. However, sometimes the patient has a bad opening aortic valve. At that time, the size of the aortic valve is not important. So I show the last video. Anyway, so in my sense, more than 10 millimeter of the aortic valve ring, it's okay to make a resection of, together with well opening cusps, we can make a resection through aortic valve. But to the middle level of the left ventricle, so more deeper aortic stenosis around the papillary muscle or others, at the time, it is better to make a modified corner procedure together with barrel sparing approach.
And the second question was, in real time, when you're, how do you identify the first septal perforator? Knowing where it should be, how do you actually identify it? What tricks do you use in the operating room?
Yeah. Anyway, so very difficult to find out where is the first septal branch. And I show in my presentation, around 50% of patients just first septal branch come from the corner of the just corner of the PA to the tricuspid valve. The first septal goes down the course. However, maybe 20% before the corner and around 30% after the corner. So 20% high risk to make an injury of the first septal branch. And first septal branch go between the right ventricular muscle and left ventricular muscle. It's also one of the key point to avoid the injury of the first septal branch. That's my information.
Thank you. Thank you very much for that excellent talk. I think we'll go on now to the next and last.
Thanks.
Okay, that was a very, very interesting talk. To move up with the program, we're gonna present Dr. Mark Heeskamp. His talk is gonna be surgical management of complex subvalvar aortic stenosis, cono and Ross cono operation. Please, Dr. Heeskamp, go ahead.
Hello there, good evening or morning or whatever it is at your place. Good to be together here. My name is Mark Hazekamp. I'm from Leiden in the Netherlands, and my task here is to inform you about the Ross cono operation. But first, let's go back to the figure of Mr. Donald Nixon Ross, who was born in South Africa in 1922 and who deceased in London in 2014. He was a remarkable figure. In 1962, very early, he started with the concept of the aortic valve homograph to replace a diseased aortic valve. And then in 1967, he did his first Ross operation, first used a pulmonary autograph to replace the aortic valve. He was also involved in the first heart transplantation in the UK 1 year later. And he did many, many, many more remarkable things. In 1982, he wrote an article in the Journal of Thoracic and Cardiovascular Surgery together with Roxanne McKay about the technique for the relief of subaortic stenosis with blunt dissection, etc., etc. I was happy that I have known Mr. Ross and met him in several occasions, that we worked together in Cordoba in Spain on the Forum Ross several times, and it was a fantastic, fantastic doctor. So let's go on with the Roscoe operation. What is exactly the definition of a Roscoe operation? It's a Ross operation, of course, and then it should be added by generously opening of a narrow LVOT. The septal incision should start under the commissure between the left and the right coronary leaflets. Then you can add resection or inoculation of fibrous and muscular tissue to make the LVOT even wider. And then, of course, you have to augment the LVOT incision by inserting a patch or using the anterior free wall of the right ventricle, the lip that is attached to the pulmonary autograft. You can do both things. There is a very good article, very good, explaining the Roscoe operation. I borrowed some of the figures in this article. It was written by Dr. Seitz from Minneapolis, and it was published last year in the Annals of Cardiothoracic Surgery. There are several landmarks that are very important for the Roscoe operation. The first septal artery, you can see it many times during the Ross operation, and it's usually not at risk with the LVOT incision. However, you have to be careful with the LAD that's also running to the border of the incision sometimes. The conduction tissue is not a risk either, as long as you stay in the line under the commissure between the right and the left coronary cuff. That's very important. So when we look at this figure, we can see everything very clearly. This is the incision into the septum. You should end at the moment that you think that the LVOT is open enough. It starts between the left and the right coronary cuff, so it should be starting directly under the commissure between right and left coronary cuffs. And on the left side, you have the first septal artery, and on the right side stays the conduction tissue. And then when you put in the autograft, you can use the piece of right ventricular myocardium that is still attached to the autograft to augment the LVOT, or you can use a patch to close this cono incision. Usually we do it like this with the autograft itself, but if it needs a bigger augmentation, then you can use a patch. Here we can see another picture. It's very similar. This is the harvested pulmonary autograft with the attached part of the anterior wall of the right ventricle, the incision in the septum between the left and the right coronary cusp again. And here is how it is attached. You can do that by continuous suture like we do, or you can also do it by interrupted sutures, of course. So the Roscoe procedure is more than adapting the usually larger pulmonary autograft to the smaller, usually aortic valve annulus. So here we see it again. If there is a VSD, then of course it's not necessary to incise the septum, but you just open the infundibular septum or the outflow septum, and then you have a wide open LVOT. So then it's a little bit different. Just resect the infundibular septum and you have a wide open LVOT, and the underside of your autograft goes on top of the ventricular crest. You can see that here. Here is the wide open septum. This is the autograft with the lip of myocardium, and you put it in like this. We wrote this down, our experience, and this was in the European Journal of Cardiothoracic Surgery in 2016. And I will just show you a few slides to make you familiar with the type of patients. So these patients with a Roscoe operation are usually much younger than the patients with a Ross operation. So here the mean age, the median age was 1 year, and it ranged from 11 days till an adult patient, as you can see here. But the majority of these patients were pretty young, and even neonates, and a lot under the age of 1 year. So they are younger, and the other important thing is that the pathology is much more complex than in the simple Ross operation. So it's not only aortic valve stenosis or insufficiency, but it's also arch interruption, coarctation, hypoplasia, AVSDs, mitral valve problems are very, very common. Problems with the left ventricular function are not uncommon. Endocardial fibroelastosis is many times found in these patients. So a more complex patient group. Another thing is that even if these patients are younger than in the normal ROS population, they already had a lot of previous procedures. Here you can see how this was in our population. So they had balloon dilatation, valve repair, repair of subaortic stenosis, arch repair, as you can see here, VSD closures, repair of AVSD, hybrid Norwood, mitral valve procedures, etc., etc. Here are some of the operative details. Of course, the Roscono operation is a pretty long operation. Here, the median cross-clamp time in our population was a little over 2 hours. And there are also a lot of concomitant operations, like arch repair, many mitral procedures, not in our population specifically, but there is also a big series from Paris where the main other problem was mitral valve pathology. And we use either a bovine jugular vein conduit in the smallest patients or cryopreserved pulmonary homografts in the older patients. Several patients died in our experience, and until here we should speak of in-hospital mortality, but there was also mortality later on, and mortality was most of the times caused not by technical details of the Roscono operation, but more by the associated pathology, because of poor left ventricular function here and here, poor left ventricular function here, AVSD with mitral valve problems, endocardial fibroelastosis, etc., etc. If you look to the overall survival of the Roscono operation, that is worse than the overall survival of the Ros operation. You can see that here, after 5 years, it's about 80% survival, and after 20 years, about 70%. So there is a continuous attrition also in terms of mortality. The freedom from reoperation for changing the RV to PA conduit is also worse than in the Ros population, because simply because these patients are a lot younger in the Roscono population. So, after 10 years, half of these conduits has to be changed. Dilatation from autograft and, reoperation for a dilated autograft and a leaking valve is not a problem of the Ros operation alone, but it also occurs in the Roscono operation, and you can see that here. So the Roscono operation, maybe with the advantage that these patients are operated at a much younger age, it's not free completely of autograft reoperation. So now we come to the conclusions. Highly complex patient population, high incidence of associated anomalies, mitral valve problems, aortic valve problems, aortic arch problems, problems with the left ventricular function. It may be small in small left heart syndrome. There may be associated fibroelastosis, a high number of previous procedures, even if these patients with the Roscono operations are relatively young when they get to operation. We have to remember that a Roscono operation is very radical. It solves the problem always, but it should be typically a last resort operation. So it's completely justified to do a lot of previous procedures before we go on and finally do a Roscono operation. It's radical, but the LVOT obstruction can always be solved after a Roscono operation. There is a low risk of aortic valve insufficiency. Again, as I said before, also after Roscono operation, there is a later risk of dilatation to pulmonary autograft later, usually starting in the second or the third decade after the operation. Reoperation of RVPA conduits was, of course, not uncommon. And there is a constant attrition rate for reoperations, and that is due to the complexity of the associated cardiac anomalies. Patient selection is very important. So dilated left ventricle, poor left ventricular function, endocardial fibroelastosis are really risk factors for mortality. Borderline left ventricles may end up later with late pulmonary hypertension. Then that's a serious problem, but then even a heart transplant cannot save the patient. So sometimes it's wiser to go and opt for a univentricular pathway. The Roscono operation has technical difficulties in neonates, especially, and in small infants, small ascending aorta. The coronaries usually have to be inserted in one sinus, especially in the small neonates. The right coronary artery needs much mobilization, etc. So this is what I wanted to explain you about the Roscono operation, and I thank you for your attention. Hope to see you soon and somewhere live on the Congress. Bye-bye.
Thank you so much, Dr. Hazenkamp. That was an excellent presentation. As we're wrapping up the session, one quick question was, many of the places don't have ready availability or access to pulmonary artery homographs. And what would be your recommendation for substitute? Do you have experience with other materials?
Yeah, our substitute for homographs is the bovine jugular vein prosthesis, the Contegra, and that works very well in the younger population. And we try to spare the homographs for the teenagers and the older patients.
Excellent. Well, thank you so much. That was really a wonderful talk.
Okay, thank you, Mike, and thank you for all the speakers. I would like to conclude the webinar. On behalf of the World University for Pediatric and Congenital Heart Surgery, I want to thank all distinguished speakers and esteemed colleagues for sharing their expertise with us today, and to all of you for joining us. This has been the 16th in our series of monthly webinars in congenital heart surgery from the World University. So please join us for the next webinar on aortic insufficiency in pediatric and congenital heart disease surgical management on the 23rd of April. So I want to remind everyone that this webinar was recorded and will be available on the WPCHS website. Thank you and have a good weekend. Bye-bye.
Bye, Michael. Bye, Pia. Thank you. Bye-bye. Bye, everybody.
Thank you very much.
Thank you.